Hey there, my name is Sadler Lindsay, and I will be presenting my practice change proposal for you. Alrighty, so first things first, my patient population. Firstly, let me tell you where I am. So, Winston-Salem, North Carolina is where this project will be presented. Um, the largest patient population in Winston or Forsyth County is actually everyone under 18 years old. It takes up 22.7% of the population here in Winston. That being said, diabetes is one of the number one leading chronic illnesses for Brenner Children's patients, which is where this project will be implemented. So those kids are the ones that we'll be focusing on today. Next is the problem. So you guessed it, diabetic ketoacidosis is the major problem in type 1 diabetic kids. It's the leading cause of morbidity and mortality in type 1 diabetics. The increased rate of readmission is what we're going to be focusing on. Now, this can be due to a lot of different things, including less access to care, lower education levels of the patient and the caregiver, limited technological resources, insurance coverage or lack thereof, and availability of continuous glucose monitors or pumps. Now, some of the ramifications of increased readmission rates of DKA are not only poor health outcomes due to mismanagement of the disease, but it's an extreme financial burden for the hospital and a waste of its resources. So, that being said, the plan I have developed is a screening tool for kids that are admitted to higher acuity units of Brenner Children's, and it'll be a screening tool that will determine how at risk they are of readmission. And in addition to that, we will be performing follow-up communication for those patients deemed higher risk after their discharge from the hospital. So who's most affected? Now, there are a lot of ways we could go on this, but I really want to hone in on the financial side of Brenner Children's, so macro. In the United States, there were over 140,000 hospital visits in the United States due to DKA. And this is about $2.4 billion. And remember, these are all preventable costs. So that's really the goal here. Some of my SWOT takeaways. I just took one from each. So number one, strengths is collaboration. Brenner's is a part of the overarching Atrium Health Wake Forest Baptist healthcare system, and they're partnered with Wake Forest University's med school. So working there firsthand, I can tell you how well in our higher acuity units we work with APRNs, nurses, physicians, the diabetes specialists, the PT and OTs on the unit. This is a really great avenue for Brenner's and a major strength. Next are weaknesses. We do have an influx of travel staff, and this could definitely pose a later threat. Opportunities is our diabetes clinic. So Brenner's has a diabetic clinic that is actually one unit above our high acuity units. So this will be a great resource for us for not only educational purposes, but implementing this tool and guiding its progress and changing whatever needs to be changed. Lastly, I have threats, and you guessed it, I kind of went back to the influx of travel staff. This, as well as a couple other things, will determine the continuity or affect the continuity of the program's mission due to just changing staff. Everyone isn't educated on it or trained on it or is aware that we're even doing it. So that definitely poses as a threat. Some barriers to implementation. I really just wanted to talk about staff resistance here and the different types of staff that may feel resistant. So number one is the travel staff. They may be unwilling to participate because they're only here for a couple more weeks. Inconsistent staff. This isn't the best word I could find, but I wanted to talk about my PRN staff and my part-time staff who just aren't there on a day-to-day basis like the full-time staff are. And they could be also more unwilling to participate because they're just not there a lot. And their time spent in the hospital is just not as near as the full-time staff. So full-time staff are probably already overwhelmed with their workload, and they may be resistant to adding an additional task, unfortunately. And then the clinic. So the diabetes clinic, I could see some resistance from them. They will be in charge of making those follow-up phone calls to the patients that have been discharged, and I could see some resistance because they already have a full set of patients that they see on a regular basis. Next is my change theory. I chose Kotter's 8-step change theory, and one of the reasons was its clearly defined 8 steps. I like that it has a very clearly laid out process, and it will be easier to backtrack if we need to. Revisiting a step, it'll be easier to see where we are in the process and moving forward with the change. Next is it's linear and methodical. So kind of backing up to that and how it's easier to backtrack. Keeping it linear methodical, it's the best tool, I think, for implementing a screening tool. This tool is not the normal. It's a new idea, a new tool that we'll be implementing in the healthcare system. So it's not a norm that needs to be unfrozen or frozen, and it's not an idea that needs to be spread. It's a very methodical change that needs to be implemented. And next is head and heart. So in addition to the 8 steps that Kotter has, they also have 4 principles, and one of those is head and heart. And I really liked this aspect of Kotter's change theory because not only does it emphasize the logical side of implementing the change, but the emotional side of it. And I think this project will really appeal to the empathy that people have towards the pediatric type 1 diabetes population and wanting to improve their outcomes and keep them out of the hospital and running around at home. Next are my quality and safety outcomes. So number 1 are decreasing the DKA readmissions. That is the number 1 quality outcome that I hope to achieve. Next is increasing the awareness. So this tool will really bring awareness to the patients who are at risk and those that may need a little bit more support in managing their illness. And this tool, I think, will really increase the awareness of that and improve the safety of the care that we provide in the hospital, because we're aware of those that maybe need some more help and we can provide better, safer care for them. And next is improving the safety at home. If we continue to do our job in educating the patients with type 1 diabetes and focusing in on our kids that maybe need a little bit more help, we can improve their outcomes overall at home because they're out of the hospital. They can better manage themselves and their chronic illness. All right, my improvement model. We are going to talk about the triple aim. So number 1 are the 3 aspects of the triple aim, and this is improving the experience of the care, improving the health of the population, and lowering the per capita cost. So number 1, experiencing the experience of the care. We can kind of talk about the equity, efficiency, safety, effective, timely, and patient-centered 6 aims that the Institute of Health Improvement has. By implementing this tool, I think we can better provide that type of care, the goal care that we want, that safe, effective, efficient care. By keeping kids out of the hospital because they're managing their disease better, we're improving the health of the population, that 22.7% of Forsyth County. And lastly, that per capita cost. The only way you lower cost is through improvement, and I really think that this tool will be a great improvement on lowering the risk of readmission. Next, we have coordinated care, and next to that, I have burden of disease. The triple aim does emphasize patients receiving coordinated care and more coordinated care and just a lessening of the burden of disease. For type 1 diabetic patients, having coordinated care is crucial for their success in managing their chronic illness. And unfortunately, that illness is never going to go away. So the more that we can lessen the burden of that, the better not only we are as healthcare providers, but um, gosh, I mean, the better that patient has at succeeding. So next, I want to talk about financials. So number one, my personnel. Um, Here I just have listed all of the personnel that need to be involved. So firstly, my APRNs and my RNs, they'll be in charge of implementing the screening tool, evaluating those results, and determining who is higher risk and why. My diabetic case managers, they'll be in charge of the follow-up with the high-risk patients, as well as supporting the RNs and the APRNs. Um, my IT techs will be in charge of developing the online screening tool and educating and training the staff on such tool. And the office manager or unit manager, there is one manager that actually oversees the higher acuity units in Brenner Children's, and this person will we will need their support and ongoing monitoring of the tool on their units. Next, I have supplies. And here we have our training supplies and our tool supplies. So number one, our training supplies, that is our video and PowerPoint presentations for educating and training the staff. And this we can also talk about is the flyers that we're going to put in the break room to promote and advertise the tool. And then the tool itself, that is the screening tool. So we will need the electronic medical record updated with the screening tool. And this also accounts for a stationary cost for the use of paper tools initially. Next, so expenditures. I took everything from that last slide and I just have it all in monetary values here. So for my personnel, the personnel's time and training will be about $3,683. The training supplies will be about $300, and the tool itself will be about $1,000. Now, the personnel training time and the time of the personnel will take about 75% of expenditures, which I did expect. That gives us a total of $4,983 as our total cost expenditure. Cost benefit. So, for my return on investment, first I want to talk about my occurrence cost. So pulled from a couple different resources, I decided my occurrence cost is about $9,000. And with about one readmission a month, that gives us 12 a year at Brenner Children's. This annual cost is about $108,000. Next, we have our expected savings. So after a year, my goal is I expect at least one less occurrence. So my goal is 11 readmissions. And that gives me an expected savings of $9,000. So my savings minus my investment gives me $4,017, which I divided by my investment again, which is $4,983. And that gives me a return on investment of 81%. Next is my implementation. So number one, I really want to spread awareness. This is going to be the first key aspect of this project taking off. I want to share information and engage with people about the readmission issue and how it relates to them. So nurses, it relates to them because preventing admissions means limiting their workload. And what nurse doesn't want a lesser workload? As far as my Atrium Health leaders and stakeholders, I want to talk about the preventable cost and how we could limit those. And overall, this project will provide better experiences and outcomes for our pediatric type 1 diabetic patients. Next, I want to seek support. So I want to dictate core groups to lead the change and influence others to join. I want to seek support from staff and leadership, but also engage interdisciplinary teams. So my IT and diabetes case managers and educators from the clinic, they're going to be crucial for the tool development and follow-up discussions, as well as the vision and brainstorming our capabilities as a project. And lastly, scheduling meetings. So in-person Zoom calls, email follow-ups. Meetings are going to be crucial for debriefing about our plan for the project and evaluating our progress and success. Communication. So kind of going back to scheduling meetings, my implementation staff will have monthly meetings. It'll be about the same day every month, just to keep everyone a little bit in the mindset, all right, we're going back on the 10th this month. This will be important for tracking implementation progress, receiving feedback and making small changes if need be, as well as keeping them updated from the team lead. Next is my leadership and stakeholders. They will have quarterly meetings. This will be more formal. We'll have PowerPoint presentations about the evaluation of the evaluating the project's progress and discussing the outcomes, whether or not we're meeting them or not. We'll talk about short-term wins. And next, we have my patients and families. They will also have quarterly, I say meetings, but there'll be phone calls where we'll update them on the project's outcomes and any positive feedback I can receive from them or tell them from my side. And alternatives. So not everyone will be able to attend these meetings. So for those not in the facility, we will make them available via Zoom. There will also be a summary debrief provided via email about the meeting itself. And for my higher up staff, my leaders and administrative leadership, I will share my formal PowerPoint presentations with them so they can have all the information that I would have provided in the meeting. Next is evaluation. So I took one from each of the 4 measures here. First is my outcome. Of course, we're trying to decrease DKA readmissions at Brenner Children's. This is the outcome we hope to achieve. My process measure is obtaining motivated staff to implement the screening tool and perform the follow-up calls. Next, a balance measure is that despite the screening tool and the follow-up communication, patients may still mismanage their illness at home and then, need to be readmitted. And an impact measure I have is that patients will experience improved hemoglobin A1C levels due to better compliance with their health regimen and staying out of the hospital. They're doing well managing their illness at home. In conclusion, pediatric DKA readmissions are preventable admissions that cost Brenner's unnecessary resources and expenses every year and impact the health outcomes of our community's type 1 diabetic children. By utilizing Atrium Health's great resources and interdisciplinary teams through the Triple Aim improvement model, we can decrease that readmission rate via a screening tool that determines the patient risk of readmission and furthermore perform follow-up discussions with our patients that are determined higher risk. Cotter's 8-step change theory will assist in gaining staff support and staying on track for change. With a return on investment of 81%, the estimated investment expenses will be worth the project cost savings for Brenner's. Evaluations and potential improvements of the plan will be monitored and discussed throughout the project's implementation, and this information will need to be consistently communicated to the team. Thank you so much for listening to my presentation, and next I just have the references that I used. Have a great day.